Hello and welcome to another emergency Q&A for families in intensive care and intensive care at home. Welcome to another live stream, and I also want to welcome the viewers that are watching this on replay. My name is Patrick Hutzel, founder of intensivecarehotline.com and founder of intensivecareathome.com, and I'm here to answer your questions today live on the show. Or if you wait for your emails that you're sending in so generously during the week, I will answer some of them today as well. But the quickest way for you to get your questions answered is to come on live on the show and talk to me directly here, or by typing your questions into the chat pad. I also welcome if you want to subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. I welcome a like of the video, a share of the video, so that we can help as many families in intensive care and intensive care at home as possible. Before I go into today's questions, what makes me qualified to host a YouTube live stream to answer questions for families in intensive care and intensive care at home? I am a critical care nurse by background, and I have worked in critical care nursing for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, and I've been consulting and advocating for families in intensive care all around the world since 2013 here at intensivecarehotline.com. And we've been helping hundreds of clients and also members. We have a membership for families of critically ill patients in intensive care at intensivecarehotline.com, and you can become a member if you go and click on the membership link, or if you go to intensivecaresupport.org directly. So we've been helping hundreds of clients and members over the years, and I can confidently and without the slightest hint of exaggeration say that we have saved many lives with our consulting and advocacy, and you can verify that on our testimonial section or on our intensivecarehotline.com podcast section, and you'll find that at intensivecarehotline.com. I'm also the founder and managing director of intensivecareathome.com. With Intensive Care at Home, we are sending critical care nurses into the home, predominantly for long-term ventilated adults and children with tracheostomies. And we're replicating an intensive care bed in the community. We're also providing services to tracheostomy clients at home, adults and children that are not ventilated. We're providing BiPAP, CPAP ventilation at home. For clients without tracheostomy, we're providing home TPN, home IV potassium infusion, home IV magnesium infusion, central line management, peak line management, Hickman's line management, as well as port management. We're also providing palliative care at home, and we're also sending our critical care nurses into the home for emergency department bypass services, and we have successfully done that for the Western Sydney local area health district in Sydney as part of their In Touch program. With Intensive Care at Home, we are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. And we are NDIS approved, TAC and WorkSafe approved in Victoria, ICARE in New South Wales, and IISQ in Queensland, as well as the DVA all around the country. We're also providing level 2 and level 3 NDIS support coordination. Okay, enough of the introduction. Let's get to our questions today. And like I said, if you have any questions, type them into the chat pad or join me live on the StreamYard link here today. Let's get to the first question from Belinda, who says, "Hi Patrick, my 88-year-old dad developed pneumonia in ICU after surgery and being in bed for 2 weeks. They want to take out the breathing tube that is helping him breathe and do a tracheostomy. He underwent 2 surgeries, 4 broken bones and left hip and left elbow. Before intubation, I was told it was to help him breathe better, and they were going to look into his lungs to see what was happening. Well, if they were going to look into his lungs to see what was happening, they would be doing a bronchoscopy, which is basically putting a video camera down his lungs and potentially suck out some mucus." Then Belinda continues, "If it was pneumonia, it could be treated with antibiotics. Now, because he has had episodes where he's not able to expel the mucus, his breathing becomes very labored and his air doesn't reach his major organs, according to them. I don't know right now the numbers, but can you ask for me with a second opinion?" Yeah, for sure, Belinda. I mean, that's what we do. If you and I were to get on a call with the doctors and nurses directly, then I can ask, what is exactly happening. Because what's happening in a situation like this, Belinda, is simply, so he's on a ventilator with a breathing tube. He had some surgery. He developed a pneumonia, and one of the main complications in ICU when it comes to ventilation and breathing tube is ventilator-associated pneumonia. The longer you keep this breathing tube in, especially when patients are in an induced coma, on sedatives, on opiates, the higher the chances are that patients will end up with a pneumonia, also because they are immobile and they're lying in bed all day, right? So a very precarious situation for many, many patients, and that's why you need to limit the time someone stays on the ventilator, right, as much as possible. The sooner you can wean them off the ventilator and the breathing tube, the better, right? The sooner you can wean them off the ventilator if they have a tracheostomy, the better. Now, the question here, Belinda, is, does your dad still need surgery? He's already had surgery, but he also has some broken bones, so he has some fractures. Does he need more surgery? How is he going with pain relief with all these fractures? Does he need more pain relief, right? If he needs more pain relief, is that a hindrance to getting him off the ventilator? Is that directly pushing him to having a tracheostomy, right? When he had a bronchoscopy, what did they find? Did they suck out some of the mucus? Did they follow up with a chest x-ray, right? So you're saying if it was pneumonia, it could be treated with antibiotics. Well, the question here is, have they sent a sputum sample? And if they sent a sputum sample, what did it show? Did it show bacterial pneumonia, viral pneumonia, fungal pneumonia? And have they now started to give him the right antibiotics, antivirals, antifungals, right? Have they started to mobilize him? Have they started to get him out of bed, right? And now also you're saying he's had episodes where he's not able to expel the mucus. His breathing becomes very labored. Yes, no surprises there. The question is, why can't he expel his mucus? Why can't he get rid of his secretions? Well, he's got the breathing tube, so it's a narrow pipe, and it's difficult to get rid of secretions unless he has a really good strong cough. But even if he has a good strong cough and he can bring up some of the secretions, the intensive care nurses would need to suction the secretions through the tube, right? Which is very uncomfortable, by the way. So the goal here can only really be to wean your dad off the ventilator as quickly as possible, get him out of the induced coma, wean off sedation, wean off opiates, right? That must be the goal here, right? Also, so that the oxygen can be supplied to his major organs. You're saying that because he has so many secretions on his chest that some of the organs may not get the oxygen they need, right? So, few questions here. Is he in kidney impairment? Is he in liver impairment? Because those would be the first organs affected if he potentially has not enough oxygen supply to those major organs, right? That's number one. Number two, is his lactate potentially going up? Is his kidney function impaired? What is urea and creatinine doing, right? What is his liver enzymes doing? Are they going off, right? Worst case here would be, is he potentially getting jaundiced, right? Looking yellow because the liver is not working, right? So he's saying, I don't know the right numbers, but can you ask them for me with a second opinion? Absolutely. You know, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's exactly what you're dealing with. So does he need a tracheostomy? I don't know, because I don't have the ventilator settings. I strongly suggest that you and I get on a call with the doctors as soon as possible, so we can ask all those questions, you know, and dig down really deep. But it would also help if you can give me access to the medical records. That would certainly also help to dig deeper there and recommend the next steps. Now, James, welcome to the show. James asking, my dad was admitted to the hospital with aspiration pneumonia. After 7 days in ICU, dad woke up and the pneumonia and sepsis, and the pneumonia and sepsis was resolved, and dad was stable and improved enough to be discharged from ICU. That's fantastic. That's such good news. That is such good news. Thank you for sharing. Did you have a question as well, James, or is it just to give an update? I think you have been here on the show before. I can't remember because I'm talking to so many people, but I think you have been here before. Dad was stable and improved. My question is, why would the palliative care team get involved and think, oh, right. Oh, great question, James. Great question. So here's what happens when patients get admitted into ICU. Very, very, very rarely have I seen someone getting admitted into ICU, and ICU will tell you, oh, you know, we will do X, Y, and Z with your dad, and it takes 3 days, 3 weeks, and then your loved one will walk out of ICU healed. You will very rarely see that. Instead, you hear from day one, oh, things are looking grim, and it's very likely that your family member is not going to survive. And you will very likely hear that if your family member is going to survive, they won't have any quality of life. So from that perspective, we better start talking to palliative care, because it's quote unquote ethical to not prolong life. Right? I do believe this is exactly what's happened with your dad's situation. The worst case scenario for an ICU team is to look after someone indefinitely with an uncertain outcome. And they're almost categorizing every single patient like that nowadays. Right? So if they think your dad could be in the ICU indefinitely with an uncertain outcome, that presents their worst case scenario. And how can you manage this worst case scenario? Well, you can manage it by creating a doom and gloom narrative, which I believe is what they've done with your dad. You know, they would have told you right from the start, keep your expectations low. He's going to die. Let's start talking about palliative care. Now, it's probably getting worse in terms of, there was a documentary last year on CBC, and this is specifically to our US audience. So this was a documentation in the US where research has been done from journalists, and some hospitals in the US, apparently, depending on the health insurance who's funding them and all the rest of it, some hospitals get incentivized to move patients to palliative care and let them pass away. Let that sink in, James. Let that sink in. So the question is, why was palliative care involved? Were they involved because they were potentially incentivized? Right? Very scary stuff. Is that an element of population control? Very scary stuff. You know, I've been saying here on my YouTube channel and at intensivecarehotline.com from day one that the system is flawed, and that it's all about emptying ICU beds, whether that's by curing people, which is great, or whether it's by letting people die. One way or another, the outcome is the same for the ICU, which is freeing up the ICU bed. Here is another element that I think is important here, James. Another element that is important is, let's just say the ICU team would have come to you on day one and would have said, hey, James, you know, a few days and we're doing X, Y, and Z to get your dad clear of the pneumonia and send him out of ICU. and he can go home in a few days or weeks, and then it wouldn't have happened. You could sue them, right? You could hold them account. So that means everything that they're saying is to protect their downside, is to protect their risk or their perceived risk, right? So you have to read between the lines. And that's why it's so important to get a second opinion from day one. So not only that you can read between the lines, but also that you can start asking the right questions, right? So James, you're saying Dad was discharged from the ICU and he had no other comorbidities. The only thing Dad had was oropharyngeal dysphagia. Yeah, great. That's fantastic. I mean, it's great that your dad was discharged, but can you now see why the narrative they're creating from day one for pretty much most patients, right? Can you see why the narrative is a slippery slope for families? Because they don't know any better. They take everything for face value. At some point, some families might realize, hang on, what's really going on here? At some point, they can look behind the curtains. They realize, hang on, their words and their actions don't match, right? I can't tell you how many families we've helped over the years. We've helped hundreds of clients and hundreds of members over the years, to get the outcomes they wanted for their loved ones. But I can't tell you how many families we've consulted over the years and helped over the years where they say, oh, they keep telling us, Dad and Mom, whoever it is, my spouse is dying. But in the meantime, they can actually see them improving. And they go like, something's not right here. And it's the words and actions don't match, right? And then you're saying, James, they lie and they say that we adamantly refuse the PEG when they never offered it. Interesting. Yeah. I think we are at the point now where some ICUs, not all ICUs, and I will also make the disclaimer here that, there's a lot of good things happening in ICU, But the reality is when people come to us here, that's when bad things happen, right? And when bad things happen, it's really bad, right? Then you're saying they mismanaged Dad's dysphagia and allowed him to aspirate and secretly starved and dehydrated Dad 12 of last 40 days. Yes, I think I remember now. You have been here before. I remember now some in the last few weeks, maybe even last week, when you were talking about they were starving your dad to death. Yeah. So, but James, does it now make sense why they're doing what they're doing, right? They're lying into people's faces when they need to, just to protect their downside, right? You're also welcome to come live on the show here, and if you wanna share more, because I think that's a good story of warning. You can just use the StreamYard link here that I just posted here. You don't have to go on camera, but I think we can talk about this more if you are talking to me directly here, right? So yeah, that's what's happening, James, across the board. It's the doom and gloom and the death narrative right from the start. And also what they're not telling you is that 90% of intensive care patients survive. That's the part they are very conveniently withholding, right? You have to do your own research and you have to look behind the curtains what is actually really happening in this world, right? Oh, no doubt that there was financial incentive, James. And I tell you where the financial incentive comes in. I presume you are in the US. I'm not sure, but I presume you are in the US. So there's two financial incentives here. The first financial incentive is, as I said, some hospitals get incentivized to let people die. And that when people die, they don't even show up in their mortality rate, right? That's part of the deal that some insurances apparently have struck with hospitals. Very scary stuff, right? And the other financial incentive is this, James. So they get paid for the ICU bed, okay? Day rate, $5,000–6,000 per bed day. And then let's just say your dad stays there for much longer with the uncertain outcome, right? Then, let's just say he stays there with the uncertain outcome. Then payments go down often, right? And it becomes a bigger burden for the ICU to deal with someone long term, whether it's on a financial or also on an emotional level, right? So then the other financial incentive is, let's just say they get your dad out, whether it's by letting him die or through other means, right? Well, the next patient is not far away. And so the cycle continues. But there are some patients that are more lucrative than others. And maybe they want to target the more lucrative patients by getting your dad out. And now you're saying, I feel that they had a financial incentive to let that dad pass away under the palliative care team. Yeah, yeah, I believe so. I believe so. You know, one has to really think about what's really going on in this world. You know, and you know why this might be more lucrative for the health insurances. To me, it's, you know, common sense. So let's just say, you know, your dad would have passed away after a few days in ICU. Well, you know, that would have been the end of payments for your dad. But let's just say he would have gone on to be treated, whether it's in ICU, whether it's down the line in a step down ICU, HDU, whether, you know, it's potentially rehabilitation, you know, they would have seen that as a burden, as a cost burden, right? And with that cost burden, you know, your dad would have not been a good quote unquote business case, whether it's for the health insurance or for the hospital. I am not in the UK, James. I am in Melbourne, Australia. However, I did do my critical care training in the UK, right? And I'm talking to people, US, UK, Australia, every day of the week, 7 days a week. So I'm not sure where you are. I think from our last conversation, I remember you might be in the US from memory. But, you know, I have a very good understanding of the US health system because I'm talking to people in the US every day, right? So it's pretty scary stuff. Would be curious to know where you are, James, whether you are in the US or in the UK, or maybe you are in Australia. I don't know. Would be good if you could share that. But one way or another, it doesn't really matter where it is, US, UK, Australia. There are financial incentives, I believe, to let people die prematurely. And that is extremely sad. It's extremely concerning, right? And it's extremely unethical. You know, there's people within the healthcare system making decisions who should live and die. That is extremely scary, right? That is extremely scary stuff. You know, I believe it's not up to you or to me, you know, when our time is up, it's up to God, as far as I'm concerned. And in the meantime, we have to preserve life. That's what I believe in. And I believe that doctors and nurses should only go into the profession to help people. And letting people die unless they want to die, that's not why people end up in hospital. You know, if there's advanced care directives, you know, that people don't want to have certain things done, that's all fine, no problem. But if there are no advanced care directives, then it's up to patients and families to decide what's next and how far treatment should be offered, you know, or how much treatment should be offered, right? So, James, I hope that sort of answers your question. But, you know, I would love to hear more about your dad's situation if you have more to share. If not, you know, if you have any questions, you know, type them. And now you're saying, James, if my dad's care was compromised because of their profit motive, it would be very incriminating for them. James, I couldn't agree more with you. I could not agree more with you. You know, I mean, we just needed to see what's happened during COVID with all the crap that was going on. And again, not unique to the US, not unique to the UK, not unique to Australia. There was so much crap going on in the medical system or in the healthcare system, it beggars belief. You know, I think many healthcare systems have completely lost their ethics and their morals. It's completely gone out of the window. you know. So so James, yeah, that's you know, that's pretty much what I can see in your dad's situation. You know, I mean, have you considered taking any action here, or will you let it go by? What are your next steps given what you've experienced here? You know, what have you experienced? All right. In the meantime, you know, and it also goes to show that unfortunately you can't trust the word of what they're saying because your dad survived, right? Your dad survived, which means their judgment was completely wrong. How can they get it so wrong if they are the quote unquote experts, right? So what's palliative care doing in the mix if your dad was improving anyway? How could they get their judgment so wrong? Is the palliative care team in some situations an execution squad? Is that what it is? We have to ask those questions. If you're in Australia, it would be difficult for you to help US families. You have no idea. I'm talking to people in the US. Most of our clients are in the US. 80% of our work in the US are in the US. So I reject that with all of my core. We've helped so many families in the US, saving lives in the US with our consulting and advocacy. Location is completely irrelevant. Knowledge of intensive care is what is relevant. That is all that's relevant, right? You can look up our testimonials. You can look up our podcast section. There's interviews with clients from the US. So I have to giggle when you say just because I'm in Australia that we can't help families in the US. We're constantly reviewing medical records in the US, and we give advice. So, you know, in this day and age, James, the internet, people can reach out to anyone. Doesn't matter. There's no geographical boundaries. Doesn't exist. You know, so when we give second opinions, for example, we look up medical records, you know, online, and that's completely location independent, right? So, you know, it's completely the work that we do is completely location independent. By email or phone, both. You can send me an email. You can send me an email here. I'll text you. I'll send you my email address. Or if you go to intensivecarehotline.com, you can just call me on one of the numbers there, and you will get hold of me. Right? You will get my cell phone directly. You can also call to me now by using the StreamYard link here. Why don't we talk now? I would be really curious to find out what else has happened there. You can just use the StreamYard link here and join me now here, but you can send me an email to support@intensivecarehotline.com or go to intensivecarehotline.com directly. There's phone numbers on the website and you can call me there. Those numbers go directly to my cell phone, right? But for anyone watching this who thinks, you know, I've never made the secret that my location is not the US, not the UK. I've never made that a secret. And we've been helping hundreds of paying clients and members over the years, saving lives. Can we always save a life? No, but we have saved plenty. I can assure you of that. And you can see that on our testimonial section. And go to our podcast section and listen to our interviews. Right. So, James, if you have any other questions, just type them into the chat pad. The quickest way is to talk to me directly here, you know, and we can nut out more of whatever needs to be nutted out. But for anyone watching this and wondering, you know, why are they saying one thing to families, but they're doing another? And why is it that people survive regardless? Well, because intensive care medicine, on the other hand, has come a long way, right? Has come a long way. And now we're at the point where we are very good at saving lives. And then people realize, oh, there's a lot of issues on the other end. What do we do when people survive and then they need care, right? It comes with the territory. It does come with the territory, right? So where to from here? You know, you have to be you have to do your research from day one when you have a loved one critically ill in intensive care. You can't be blind to the forces in intensive care, and you have to use your own judgment. You have to use discernment, and you need to find out very quickly what you don't know, and there's lots that you don't know, and then when you find out what you don't know, then fill in the gaps through professional advocacy consulting. Go to our website intensivecarehotline.com and then engage with us here. We will handhold you through this once in a lifetime situation. Okay, so if there are no other questions, or there's James. Hang on. James, welcome to the show. Can you...
Hi, Patrick. Can you
James,
hear me?
I can hear you loud and clearly. Can you hear me?
Yes, I can hear you. You're continuing. Let's see. Are you continuing on YouTube right now? Are we live on YouTube?
We are live. We are live on YouTube.
Okay. So Dad was admitted to the hospital with aspiration pneumonia. He had oropharyngeal dysphagia, and basically after 7 days, he woke up. His sepsis and pneumonia was resolved essentially, and he was deemed well enough, stable and well enough to be discharged from the ICU to the medical ward. So Dad was conscious, he was awake, he was communicating with us. Now, English is not his native language, it's his second language. So I understand that under cognitive fatigue, Dad will be communicating in his native language. So on the ward, the following day, this one palliative doctor essentially makes the unilateral decision, to not offer Dad PEG. And this was done without any informed consent from the patient, nor the family. And from there on, they essentially hid PEG from us, and they were going to give him over the weekend. This was on a Friday, to see if Dad regained his swallow function. And by the following week, if he did not regain his swallow function, they noted in the medical records that they were going to allow him natural death. Summarily, that's all in the medical records, that they were going to see if Dad regained his swallow function over the weekend, and by the following week, if he didn't regain his swallow function, they were going to let him basically have natural death. They weren't going to help him. Is that course of action considered just and right? It just doesn't.
Well, from what you are describing here, James, that could be an attempt to euthanize, or I argue that might have been an attempt to euthanize your dad. Euthanasia means the hastening of death. Euthanasia is illegal in the US.
That is correct.
That would be my interpretation of the situation, right? Which in any state in the US, you don't need to, if you want to share your location, you can. If you don't, that's fine too. But I can assure you, we've done the research. In any state in the US, there is no such thing as a unilateral decision to withdraw treatment. It doesn't exist.
And mom is.
I can't hear you, James.
But mom expressed in 6 different ways she wanted to defer to me any decisions. She also expressed, and this is all documented in the medical records, she also uh, said to them that they needed to get my permission to do anything. She also expressed that she didn't want to make any decision without the agreement of me, of her son. So she's expressed all 6 different ways that I was a essential part of the decision making process. Yet they kept me in the dark. They stonewalled me, and all of this I've only been able to obtain through the careful analysis of the medical records. I mean, when I was there at the hospital for 15 days, I mean, things were happening, and when you're in the hospital, you don't know what's wrong with your dad. He's conscious, he's awake. What's going on inside of him is hidden, unless they're telling you what the matter is.
Yeah.
So I'm in the dark. They're not keeping me updated on dad's swallow function, the status of his dysphagia. But anyways, what I've noticed was that there was a deterioration of his condition, looking at his symptoms. And so when I looked carefully at the nurse's notes, virtually almost every day, the nasal gastric keel tube, the nurses are noting that they're clogged, they're clamped. So essentially, dad was being starved to death. And in the first meeting, the palliative doctor was saying, do not resuscitate, do not feed, it's a done deal. And I was saying, what are you talking about? No one is saying not to feed dad. And he was brushing off what I was saying, and he was just shrugging it off. And they were wanting to take out the nasal gastric tube out, and I got the feeling that they were wanting to do that to wean dad off of the nasal gastric feeding tube, but that wasn't the case. Their desire and intent was to take out the feeding tube and start starving dad, or risk him getting aspiration pneumonia again. And they state in the medical records that they won't be providing any more antibiotics, that we agreed with no antibiotics, and we were okay with dad getting aspiration pneumonia again, which we were not. But they never expressed that to us. They're basically lying and covering up in the medical records that they offered us PEG, that they gave us 2 choices, whether comfort care or PEG. And none of this was done while we were in the hospital. They're making up all this in the medical records to cover up for their oversight or their mistakes, their gross negligence.
I'm not surprised in the slightest by what you're sharing. Not surprised in the slightest. It's the medical field now. It's a bit like, we decide who lives and dies. They have no qualms to, do what they think is in the best interest of them, not what's in the best interest of your dad. Because let's just say your dad would have died, it definitely wasn't in the best interest of your dad, was it?
No. I mean, dad was a fighter. He wanted to live. Yeah. And we're in a Western American hospital, and this was my first instance of being in a hospital, and growing up in the U.S., I'm thinking they're going to do everything to help Dad get better. That's the mentality that I had. I didn't know that they were doing all this behind my back, behind our back.
Yeah.
That their real intention was to let Dad pass away at the hospital. Dad wasn't dying fast enough, so they were starving him essentially, secretly. And after basically 10 days of starvation, Dad was still not dying, so they took out the IV line and basically they were going to dehydrate Dad to guarantee that he died.
Yeah.
I mean, this is all in the medical records. Yeah. On Monday, I'm going to be contacting medical experts to. I've had to basically spend the last 6 months writing my own narrative to correct the fabrications and the lies that they wrote in the medical records. Things that didn't happen, just gross exaggerations. Because if you read what they wrote in the medical records, of course, it sounds like they did everything according to the standard of care.
Right.
I mean, they're going to write things that they should have done, but in reality, they didn't do all those things.
Yeah.
So
no, it's unfortunately, James, it's a crude awakening for families when they realize what's really happening. Like you said, I went into the system, 25 years ago, believing, in the mission as a nurse or doctors and whatnot. And then over time, you realize what you see is not what you get.
No, it's more than just eye awakening. This is, to me, it's just, they don't have the right. That first palliative doctor that just unilaterally decided not to provide PEG. I mean, he is not. They don't have the. I mean, they don't have the right to give themselves the power of life and death. This wasn't. He gave himself that. He was the jury, judge, and executioner all bundled together. Yeah, and that's if this goes to trial, we'll let the jury decide.
100%. But this is absolutely, and this is exactly this is exactly what we're experiencing every day. The problem is that the reason they're getting away with so much negligence is that families don't question. They don't question.
Yeah, I imagine this isn't the first case. This was, they've gotten away with doing this sort of stuff with other families. The chaplain, in fact, writes in the medical records that unless the patient, Dad, asserts himself, basically that Dad doesn't want any more medical intervention, or that his condition precipitously gets worse, that they can't just let Dad die. I mean, of all people, chaplain is saying this. And the chaplain, we got to talking in the hallway for like 10, 15 minutes. So he knew what Dad meant to me. And I think that's why he knew, to what sort of length I would go if they just let Dad die. So that's why he's warning his colleagues, unless the patient asserts himself or his condition gets precipitously worse, that, because of concern for me. Mom doesn't have concern for me, but it's their cold word amongst themselves, basically telling his colleagues that they can't just let Dad die. So he even warned them in the medical records, saying that. And these palliative care people, they essentially, it's essentially one guy, two docs in their 30s. They're young, and then there's this one nurse that I don't even know who she was, but she's made 4 medical record posts, which are just I mean, they're just lies. They're cover-ups, basically. And I have to find out whether those were inserted out, after Dad passed away, or because I don't know who this nurse is. The other nurse I do know, and yeah, it's this palliative care team. They worked as like a tag team, basically, to kind of, to make this scheme, this elaborate scheme to cover up and give the perception that Dad was a dying man, but he wasn't. He wasn't dying of anything. He didn't have any comorbidities. Before Dad got aspiration pneumonia, he was able to do everything fine. A few days before he was admitted to the hospital, he could do everything you and I could do. So this was an acute illness. It wasn't a chronic illness. And they're treating his situation as if it was a chronic illness. That, the doc is writing to not prolong his suffering and so forth. But the thing is, Dad wasn't suffering. It's not like he had cancer for, many, many months and with ineffective treatments. This was an acute illness. You can't, just because Dad is an older patient, you can't summarily treat him like a dying patient.
Absolutely not. Absolutely not.
You can't age discriminate him. Who knows? Because, he could have lived another 15, 20 years. No one can say.
No one can say. How old is your dad?
Dad was 88.
Right.
But you have to understand his family history. He has 3 other sisters and 2 other brothers. They're all alive. They're all in their 80s and 90s. Dad's mother lived to over 100 years old. Dad's older brother is 8 years older, so he's 97, and he's still doing just fine. So,
yeah. And your dad is still alive and well?
Right now?
Yes.
No, Dad suffocated to death because of their mismanagement and non-treatment of Dad's oropharyngeal dysphagia.
But didn't you say your dad left ICU and then went to a medical ward?
And at the medical ward, they botched his care of his dysphagia, and they starved him basically for 12 of the last 14 days. So he became mortally weakened by starvation, and they didn't do anything for his dysphagia. So Dad was left to try and eat and survive, or die of starvation. So when he tried eating, it went right into his lungs, and Dad suffocated to death.
Yeah, right.
So this is a medical wrongful death, lawsuit that I am pursuing.
Right.
As a result.
Okay. How long ago was this situation?
We're coming on to 2 years. It's not quite 2 years. Dad died in November, the end of November, 2022. So the tail end of the COVID virus pandemic, essentially. And I've had people say to me that, if Dad died in the hospital, that, they may have gotten some additional COVID money. And
100%. I sent the link to the documentary in the chat pad here. How to avoid the trap of the medical industrial complex. I encourage you to check that out to verify what I said, that some hospitals in the US get incentivized to put people to palliative care, and they get incentivized by the health insurances.
That is 100% what I'm thinking, that, why would they have gone through this elaborate, extra work of doing this? I mean, all they have to do is sit Mom and myself and Dad down together and just have a chat with us for 10, 15 minutes. And, we would have probably wanted the peg done. Then we could have taken Dad home where he's emotionally, psychologically, and medically would have been best. Why leave
100%.
dad in isolation for 14 days, 14 hours a day, because our visitation was from 9 a.m. to 7 p.m. and all this starvation was happening, clogs happening in the nasogastric. I mean, this was an elaborate scheme that they designed so that dad would pass away at the hospital under the care of the so-called palliative care team, and they must have had some financial motive in doing this. That's
100%, James. 100%. Unfortunately, there are financial incentives, and I also believe there is an element of population control that some people have an interest in.
So, are you? I mean, do you have some expertise in medical experts?
We do medical record reviews. We have some legal nurse consultants on our team, right, that can do medical record reviews. So they're all critical care legal nurse consultants.
Here in the U.S., we need to get something called like certificate of merit or affidavit of merit, and
Yeah.
it's a process, basically highlighting, who the caretakers were, what the education of the medical experts, basically the full the foundation, and what what are the issues that are being questioned, and why the medical expert believes that these standard of cares were not met. So it's a kind of a involved document that the medical expert has to produce. So our family is willing to pay the expense of doing that, and I've written over 100 pages of documentation documenting all the evidence within the pages of the medical records. The medical record itself is about 490 pages of actual written text. It's a lot of it is redundancy. So I'd say only about 88 pages of original text, and then they're just basic duplicated, passing down.
How long? I'm sorry to interject, James. How long was the hospital stay for in total?
That was admitted on November the 3rd, and he was discharged on the 25th. And we have three meetings, and just right on the first meeting, they were saying 5-day feeding trial, 5-day feeding trial, and when I heard about the third time, I said, "What's this 5-day feeding trial? Why not 6 days or 7 days? Why even have an artificial number of days? It'll give him as long as he needs to be able to safely eat." I didn't know what the hurry was. So I've documented all in writing for the medical expert to read. And I said, Medicare will cover up to 3 months dad's hospital stay. So I didn't get what the hurry was. So I'm telling them all this, and I'm saying that dad's heart is strong, his mind is good. There's nothing that's going to kill him. His organ systems are fine. So everything that I was saying was alarming the hospitalist so much that there was another hospitalist that was there on the other side of the palliative care, and she, there's a lot of things you can tell from the body language and her expressions. So everything I was saying was alarming her. So she goes, "If you want to feed your dad, we have to do it right away." So that kind of gave me the sense of urgency. And when I use artificial intelligence to ask a lot of the questions that I have. The chat GPT is really good, and I probably would not be able to pursue a lawsuit without it. And one of the questions I ask is, what's the standard of care for a clogged feeding tube? And the standard of care is it should be resolved within a couple hours, and if it's still not resolved within 6 hours, it's considered a medical emergency.
Yeah.
And here we have Dad, day after day, the feeding tube's still clogged, and I'm the one that actually found where the clog was at. It was right at the nostril where it makes the turn, right at the nose, and it was taped over with 6-7 strips of white hospital gauze tape. And I always wondered why there were so many right at that entrance holding the tube. And so when I peeled it one at a time, sure enough, right there was a crimp. And about a week later, Dad had a nick cut right there at the tip. And I took a photo of that because there's no way that Dad could have gotten a cut right there. Someone, I believe, was sabotaging, used a pocket knife to create the crimp, which they were taping over, and on their way out, they nicked the tip of Dad's nose, and that's why Dad had that cut. So I have a photo of that cut. So just the fact that they hid PEG from us, a nurse notes that PEG is not an option.
That's medical negligence. That's medical negligence right there and then, by withholding information.
Yeah, PEG is not. I mean, the nurse is writing this, so they're telling the nurses not to mention PEG in front of the family. Yeah. So, I mean, if we go to trial, all of this evidence, and I documented all this evidence in the 100 pages I've written, and hopefully the medical expert will read all this, and we'll follow up, link it to the medical record, and see the negligence that exists here. And I mean, you have to understand, Dad was everything to me. I mean, he was almost 98% of the fund that we had. I mean, I don't have a family of my own yet, so Dad was my family. I had great, I had great
memories.
Well, I have, yes, sure, definitely great memories. But I took great pride in taking good care of Dad. My dad was 88 years old, and I took great pride in helping Dad stay healthy. Dad had lost all his teeth like 3-4 years prior.
Right.
And we got him dentures, but he wasn't using them. So my suspicion is that Dad wasn't getting the essential amino acids, which are found in meat and nuts, which are harder to chew items. So his neck muscles consequently became atrophied, and his neck muscles were failing him. That's why he got his aspiration pneumonia. But with PEG and with months of rehabilitation and proper nutrition, he could have regained that. Malnutrition
100%.
can come back.
James, I'm sorry to interject there. I will need to wrap this up in a minute because, I usually schedule this for an hour. I do need to wrap up the call now because, I only have an hour for these calls. But I would love to continue the conversation. We can definitely help you with a review with one of our critical care legal nurse consultants if you are interested. It's probably best if you either reach out to me over the phone. If you're in the US, I'll just post you my phone number here. That is my US phone number, and this goes directly to my mobile, or you can send an email to my cell phone, or you can send me an email to support@intensivecarehotline.com. I also have posted this link, the Rumble link here, about the documentary that I was talking about, that some hospitals are being incentivized by health insurances to let people die, right? But I do need to wrap this up here, James, because I've got, busy. I'm a busy person.
That's just outrageous.
It's outrageous. It is absolutely outrageous, and that's why I'm doing these podcasts and shows. People need to know. People need to know what's happening in the real world.
Absolutely. Now, if you're in Australia, how many hours ahead of Pacific are you?
Pacific currently 17 hours.
17 hours, okay. And what's the best time to reach out to you, in the morning?
Probably if you're Pacific, after 2 or 3 p.m. your time, best time.
Okay, all right. Okay, Patrick, I appreciate you. Maybe I will shoot you an email, and then we can set up a time to chat.
That would be great. That would
further.
be great. That would be great.
Okay.
Thank you so much, James, for sharing your story, and I'm sure we'll talk again.
Okay, sounds good, Patrick.
Thank you so
have a
much.
good day.
Thank you. Thank you, and you. All right. Thank you, James, for sharing. So I'm going to wrap this up. Go and check out intensivecarehotline.com for our membership. I also do one-on-one consulting and advocacy. We do medical record reviews in real time, but also after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence like James does. With intensive care at home, go and check out intensive care at home for home care, for a genuine alternative to a long-term stay in intensive care. And please like the video, subscribe to my YouTube channel for regular updates. Share the video with your friends and family so that as many people know about intensive care hotline and intensive care at home and about what's really going on in the medical field. Comment below what you want to see next. I do these YouTube lives every week, Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is currently 8:30 p.m. Eastern Standard Time on a Saturday night in the US, or 5:30 p.m. Pacific time. Thank you so much for watching, and I look forward to seeing you again here next week. Look out for my quick tip videos during the week. Take care.